Is my audio and video okay? Yeah, perfect, perfect. Okay, so we can start the session now. And I think there are many questions for anatomy, and I think it won't be like possible for me to cover the entire anatomy PYQ session of NEET-PG in one session, right? So I'll be taking it in two sessions. So half of the questions I'll be discussing today, and the remaining we will discuss tomorrow, right? So here we go. The very first question was about a person with midline swelling, and this actually moved with tongue protrusion, right? So the moment you have these kind of hints, it is quite easy to make a clear-cut diagnosis of. So I think everyone can make a clear-cut diagnosis. The swelling is in the midline, right? So it is in the midline, something like this, okay? And it has a classical property of movement, or and this especially seen with the protrusion of tongue and also with deglutition movement, right? So if you tell the patient to do a swallowing movement, it will be moving, and if you tell the patient to protrude the tongue, it will also move up. And that is because, yes, so I think everyone can make a clear cut. So Varun, cool kids, yes, all of you are correct. This is thyroglossal cyst. Now thyro word is related to the thyroid gland, and glossal is of course the tongue, right? So glossal word is from glossus for tongue. So if you look at the course of this thyroglossal tract actually, so it has communication from the tongue around the foramen cecum, and it extends till the thyroid gland, right? So therefore, whenever there is any movement of the tongue, if we tell the patient to protrude the tongue, this cyst, if it is there, it will definitely move upward. So this is one thing. And similarly, if you tell the patient to do a swallowing movement, again it is going to move. So it shows that there is some connection of this particular cyst with the tongue, right? So this is thyroglossal cyst, and usually it is in the midline below the hyoid bone, right? So usually it is below the hyoid bone. So here you can see this one is the hyoid bone, right? So this is the hyoid bone, something like this, okay? So usually it is below this, and it is said that it is in the midline, but it can be slightly on the left side sometimes, right? So this is thyroglossal cyst, and again this is a very favorite topic. Now the next question is very beautifully framed. Now there was a anomaly which was given in the picture, and it was asked like which aortic arch artery is responsible. So this is aortic arch artery, right? So the image was shown, and it was about, the concept was about the derivatives of aortic arch arteries. Yes, so anyone would like to answer this particular question. So here you need to understand two things. So first thing, you have to make the impression from the image that what actually is shown in the image, right? So number one, you have to identify that, and number two, you have to associate it with embryology, so embryological basis. Yes, so Varun told it is remnant of 6th left aortic arch. Yes, very good, Varun, you are absolutely right. So this is very important, like remnant of course 6th aortic arch, but specifically left side, right? So this is very important, specifically left side, because the structure which is shown in the image is actually the ductus arteriosus, right? So this is the ductus arteriosus, and since it is an adult, so you can call it patent ductus arteriosus, right? Because in fetal life this is a normal entity, but in a newborn or in a child or adult, it is always pathological because it should not exist after birth, right? So you can call it patent ductus arteriosus, right? So you can see this is the aorta, right? So this is the descending aorta, and here is the, you can say this is the pulmonary trunk, right? So there is a communication between the pulmonary trunk and the aorta, and this is the ductus arteriosus. Now ductus arteriosus is derived only from the left part of sixth aortic arch, right? So sixth aortic arch artery, right? So this is very important. It's only on the left side, right? So don't get mixed up. So this is the entity which has been shown in the image, and this is the ductus arteriosus. Okay, so this is the ductus arteriosus here, which is communicating the pulmonary trunk. So this is the pulmonary trunk, something like this. Okay, so this one is the left pulmonary artery, and this is the right pulmonary artery, and this is the arch of aorta, which is continuing as the descending aorta. So we can see this is the communication here. Okay, so we can see this is the communication here, right? So this is the patent ductus arteriosus, and if I show you it in the image, now this is the main pulmonary trunk. Okay, this is the right pulmonary artery, and the proximal part of the sixth forms the left pulmonary artery, right? And here we can see this is the ductus arteriosus. Okay, so this part is the ductus arteriosus, which is a normal and useful entity in the fetal age group. And then this is all aorta. Okay, so this is all aorta, right? So this structure is ductus arteriosus, and it is derived from the sixth aortic arch artery, but on the left side. So this is the left side, this is the right side. Fine. So left side distal portion of the sixth aortic arch artery give rise to ductus arteriosus, and this is a valuable structure in fetal life, and once the baby is born it is obliterated, and the remnant what we see in adult life is ligamentum arteriosum. Clear? So this is the normal anatomy, but if it persists, then obviously that is pathological and should be addressed. Okay, so this is remnant of sixth aortic arch artery, so patent ductus arteriosus. Now next question was about a patient who had wide yawning, and after that his jaw get stuck. So which muscle is involved here? So this is again a very basic concept, but it has been framed into a clinical question. So let me see if someone can answer that. Yes, somebody would like to answer this. Very good, Varun, very good. Now this is a simple concept, like yawning means opening of mouth, right? So yawning means opening of mouth, and we have already discussed that whenever there is opening of mouth, it is only the lower jaw which actually moves. Upper jaw is fixed, so lower jaw goes downward, right? And when it goes downward, we use the term depression, right? So it's opening of the mouth, that is depression of the mandible. And this depression is brought about by two factors. Number one is, of course, gravity, because it is in the direction of the gravity. And second is the lateral pterygoid, right? So this question is nothing but just the action of lateral pterygoid, right? So this is the concept behind this particular question. So a very simple statement has been, presented in such a complicated manner. So it was nothing except the thing like depression of mandible, which was asked here. Okay, so here we can see the two heads of lateral pterygoid. So this is the on the upper part, on the upper side is the superior head. Okay, so this is the superior head, and on the lower part we have the inferior head. So this is the inferior head of lateral pterygoid, right? So these are the two heads of lateral pterygoid. Fine. So depression of mandible or opening of mouth. Now the next question, there is an endoscopic image of the nasopharynx, and then one structure was marked with a white arrow. Can you identify that? What is this structure? Yes, anyone? What is this structure here? I'm just hiding the options, so let me see if you can answer it without searching the answer from the options. Now this is a very important landmark in terms of tumors of nasopharynx. So if I show you the options, I think it will be very easy for you to mark the answer. Yes, anyone? Cool kids. Okay, I think you can just mark from, you can just search out the answer from the options, right? So Varun, very good. So this is actually adenoid remnants, okay? Because we know that adenoid, it gets atrophied by around 11 to 12 years of age. So that remains as adenoid remnant. Now here you can see one opening, and this opening is the Eustachian tube, right? So this is the Eustachian tube, clear? And then this one is the fossa of Rosenmuller, and yes, I think most of you must be knowing its importance in terms of the nasopharyngeal malignancy. And this prominence is actually the torus tubaris, right? So just remember these two important things here. One is the Eustachian tube, and second is the fossa of Rosenmuller, right? So just remember these important two. So now you can just take it on another side. Okay, so here you can see this is the opening of Eustachian tube, right? So this is Eustachian tube. Here you can see there is fossa of Rosenmuller, and this is all torus tubaris, right? And this is all the place where adenoid was present in childhood, right? So this is the appearance of nasopharynx. Okay, so please remember nasopharynx because it is one of the favorite areas, or in fact the topic as such is very important. Now let us take another question. A patient has swelling and pain, right? And you can see the swelling here. So this is the swelling in this area, right? So this is the area of the swelling. Now, which nerve will carry the pain sensation from this area? So to answer such questions, you have to you must have to know what is the nerve supply, or what is the cutaneous nerve supply of this particular area, right? So any idea which nerve supplies this particular area? Yes, Varun, this is great auricular nerve, right? So this is the territory of the great auricular nerve. Fine. So therefore any pain sensation, the cutaneous pain sensation would be carried by great auricular nerve. And to be more specific, you can see this all area is the territory of the great auricular nerve, right? So this all is the territory of great auricular nerve involving the angle of the mandible. Okay, so this is all territory of great auricular nerve. Chalo, next question. Now this is a good question, and there is a stab injury. Okay, and then after that the knife got stuck in the lateral part of the dorsal column. So what loss would be seen? So there is a stab injury, and the injury has occurred in the lateral part of the dorsal column. Now what okay, now see, to answer this type of question, you have to understand two things, right? Number one, like this is about the loss, so it is of course a ascending tract. Now which tract is discussed? Number one. And number two, what is the course of the tract? And this is especially in terms of decussation. And I think most of you must be knowing what decussation is. Decussation is the crossing over. Now in this particular case, I think everyone can clearly point out that we are discussing the dorsal column. Now tell me, what is the point of decussation of the dorsal column? So if we discuss about dorsal column, yes, anyone, what is the point of decussation? What are the sensations which are carried by dorsal column? It is of course proprioception, stereognosis, okay, and 2-point discrimination, vibration sense. So this is all carried by the dorsal column. Now the dorsal column, it ascends, and the decussation occurs in, yes, what is the area of decussation of dorsal column? Anyone? Where decussation of dorsal column occurs? It is in medulla, right? And from medulla, the fibers, they cross onto other side and they ascend in the medial lemniscal system. Clear? Then they reach thalamus, and from thalamus there is origin of the third order neurons, which finally terminate in, yes Varun, you are absolutely right, this is medulla. Now if there is injury on, suppose if this is left side, it means if there is injury below the medulla on the left side, the sensation would be lost on the same side, right? So if I am saying left, it means the loss will be occurring on the left side, so that is ipsilateral, right? Number one. Then we have already discussed the modalities, so it means ipsilateral proprioception. Now the third point which you have to answer here is whether it is in arm or whether it is in leg. So anyone who can tell me whether the sensory loss would be occurring in the upper arm or the leg? Yes, anyone? And to get up to the point, you have to notice this point, lateral part of the dorsal column. Very good, Varun, because lateral part is having cuneatus fasciculus, and that is taking the sensory modalities from upper limb. The gracialis, which is most medial, is taking the sensory modalities from lower limb. So lateral part means there is involvement of fasciculus cuneatus, and therefore the answer would be proprioception loss in ipsilateral arm, right? So there are 3 points which have to be addressed in this particular question, and therefore you can get your answer something like this. Now we can take the concept once again in terms of image. So this all is the dorsal column, which is also known as the posterior column, right? So on the medial side, this is fasciculus gracialis, right? So this is the fasciculus gracialis, and on the lateral side there is fasciculus cuneatus. So this is the fasciculus cuneatus. So same arrangement on other side as well. So this is the fasciculus gracialis, and laterally there is fasciculus cuneatus. Fine. Now cuneatus takes the sensations from arm or what you call upper limb. Okay, so this is also, you can write upper limb, and the gracialis takes from leg, or you can say lower limb. Clear? So the sensory modalities are same. It is just that the areas from where the sensory modalities is different. Okay. Okay, yes, Varun, you are absolutely right. But when it is said that it is in the neck region, yes, your point is valid, Varun. It's not specifically mentioned that it is below the medullary region. Okay, yes, but when we say that it is in the neck region, okay, when we say in the neck region, we presume that it is below the level of medulla. Yes, but yeah, it's not specifically mentioned, of course, right? But neck is like below the medulla, right? So this is the whole description in terms of this question, right? So lateral part injury, it means this area is involved, the lateral part of dorsal column. So if this area is involved, it means there is involvement of the fasciculus cuneatus. And yes, if it is specifically mentioned that it is below the level of medulla, you can say that the same side modalities would be lost. So proprioception, stereognosis, 2-point discrimination or vibration sense, right? So this is how you should solve these kind of questions. So again, for that you need to have a thorough knowledge of the anatomy and of course physiology, right? So in terms of the course, in terms of the sensory modalities carried by that particular ascending tract, right? So this is for dorsal column. Now next question is quite easy question, and I think most of you can answer it the moment you look at the CT scan image. And just to help you, I'm also giving you the options. So elderly patient, there is a history of fall, and now he is having headache, dizziness, ataxia, and then there is history of alcoholism, and this is the CT scan. Now what you can interpret from this particular CT scan? So I think it is one of the very commonly repeated questions, and there should be no confusion in this whatsoever, right? So anyone, what can be the answer here? Yes, anyone? What can be the answer here? You have got a very classical history. Elderly patient, alcoholic, there is history of fall, and then the CT scan. One very good, Varun. This is a classical presentation for subdural hemorrhage, right? So this is a classical presentation for subdural hemorrhage. Okay, and we know that in subdural hemorrhage, what is the source of bleeding? That is the bridging or emissary veins, right? So when I say subdural, so sub means below and dural is of course the dura mater, right? So between the dura mater and the arachnoid mater. Okay, so this is subdural hemorrhage. And just to highlight few points, this is between the dura mater and the arachnoid. You can see the classical banana shaped appearance, and there is tearing of the bridging veins, and the CT scan appearance is crescent shape, or what is known as banana shaped, right? So this is subdural hemorrhage, and I think there is no point in doing any sort of mistake in this particular question. So subdural hemorrhage. Again, this is a very commonly repeated question, and impaired dorsiflexion of the foot, and these are the few areas, and you have to just point out like a fracture at which of the following site will impair dorsiflexion at the foot. Yes, anyone? Fracture at which of the Deepak bhai, just give me some time. I'll definitely do in Hindi. Don't worry for that. That's my promise. Just give me some time. I'll definitely do. Right? So whatever the sessions I am taking in English, I'll take them in Hindi also, just before your exam. So don't worry for that. That's my promise. See, the question is about loss of dorsiflexion of foot, right? So okay, let me explain the concept, and then I think students will get to know whether they were wrong or right. So when we say there is loss of dorsiflexion of foot, it means there is paralysis of dorsiflexors of foot. Okay, now the dorsiflexors of the foot are supplied by, because muscles, they will paralyze only if the parent nerve which supplies them gets paralyzed, right? Muscles without intact nerve supply don't paralyze, so there is paralysis of the supplying nerve. So these dorsiflexors are supplied by deep peroneal nerve, right? And this deep peroneal nerve is a branch of common peroneal nerve. Okay, so this is a branch of common peroneal nerve, and common peroneal nerve winds round the neck of fibula. Clear? So whenever there is a fracture of neck of fibula, there is possibility that this common peroneal nerve might get injured, and when the common peroneal nerve will be injured, obviously the deep peroneal nerve and the superficial peroneal nerve, which are the components of that, which are the branches of that common peroneal nerve, will also be damaged, and therefore there will be loss of dorsiflexion. So if we draw the course of the common peroneal nerve, it actually comes like this. Okay, and right, so this is the common peroneal nerve, this is the deep peroneal nerve, and this is the superficial peroneal nerve, right? So if there is any fracture here, there is all possibility of the injury to common peroneal nerve, right? So that is the concept behind this question, and this is again a very favorite question. Sometimes they will give you bone, sometimes they might ask you an x-ray. So please remember this particular concept, and I am very sure you won't do any sort of mistake later on, right? So if we see here, see, this is the sciatic nerve, okay? This is the sciatic nerve, and sciatic nerve has two divisions, tibial nerve and the common peroneal nerve, right? So this one is the common peroneal nerve, which is coming down and winding down the neck of fibula, right? So this is the common peroneal nerve, and then common peroneal nerve divides into the deep peroneal nerve and the superficial peroneal nerve, right? So this is superficial peroneal nerve, and this one is the deep peroneal nerve, okay? So this deep peroneal nerve is actually the nerve which is supplying the dorsiflexors of the foot, namely tibialis anterior and extensor digitorum longus. Mainly these are the two, these two are the dorsiflexors of the foot, right? So this is the description for this question. So here, this is the neck of fibula. So whenever there is fracture over this part of the bone, there is possibility that common peroneal nerve might get injured and patient might develop loss of dorsiflexion of foot, and therefore it is your duty, whenever you are seeing a case of fracture neck of fibula, try checking for dorsiflexion of foot. If it is absent, you can tell the patient right at that moment of time that, see, your fracture has caused a damage to this nerve which has resulted in loss of dorsiflexion of foot. Otherwise later on he might blame you for that paralysis, right? So it is your duty to document right at the time of injury. And related to deep peroneal nerve, there is one more important point. Yes, KK, absolutely right. Yes, this is foot drop. Yes, this is nothing except foot drop. Very good. So this is nothing except foot drop. And there is one more important point which I want to tell you in relation to deep peroneal nerve, that it supplies a very small area here, right? So this is the first dorsum of the first web space, and this is the point where the deep peroneal nerve gives sensory supply. Surrounding area is the territory of superficial peroneal nerve, but this small area in the first dorsal web space is the place where deep peroneal nerve gives sensory innervation, right? So this is again a very important topic, and many times we have a question from this segment in one or another way. So please remember this much, okay? Chalo, next question. And this we have already discussed while we were discussing questions in anatomy of FMG PYQ session. So a patient has cirrhosis. Consequent to that, he developed portal hypertension. And the question was about opening of portosystemic anastomosis. So out of the four options, which option is actually a place of, or actually a site of portosystemic anastomosis, and there will be opening of that area. So portal hypertension, when the value of portal pressure is more than 12 millimeter of mercury, this is known as portal hypertension, right? So anyone who can tell me which of the option actually is the site of portosystemic anastomosis. Now when I say the word porto, this is related to portal vein, and systemic is related to systemic veins. Yes, anyone, which option seems right for you? And even when we are discussing this PYQ in Yes, absolutely right, Varun. Absolutely right. This is left gastric vein and hemiazygous vein. Now, when I was discussing the yes, cool kids universe, perfect, KK, perfect. Now, there are three areas which you should remember at least, right? One is lower end of esophagus. Clear? The second is lower end of anal canal, and the third is umbilicus. Clear? So these are the three areas where there is formation of the portosystemic anastomosis, and whenever there is increase in portal pressure, these anastomosis they open up, and if there is opening of the anastomosis here, this leads to hematomasis. Okay, this is hemorrhoids. Okay, and this is the manifestation is caput medusae, right? So this is the clinical correlation of this concept. Now, as far as the lower end of esophagus is concerned, we have one vein which is a part of portal system, and that is the esophageal branch of left gastric vein. There is another vein which is the part of the systemic venous system, and that comes from hemiazygous vein, right? So these the branches of these two veins, they anastomose around the lower end of esophagus. Okay, so this is the lower end of esophagus. So left gastric vein tributary from the portal system, and hemizygous vein tributary from the systemic venous system. They anastomose around the lower end of esophagus, and whenever there is portal hypertension, this anastomosis opens up, and this results in varices. I think most of you must have heard this word, esophageal varices, right? So this is one important thing which you should know. Now, as far as the portocaval or portosystemic anastomosis is concerned around the lower end of anal canal, it is between the superior rectal vein, which is the tributary of the portal system, and inferior rectal vein, which is the tributary of the systemic venous system, right? So superior rectal and inferior rectal around the lower end of anal canal. And the third one is around the umbilicus, and that is between the para-umbilical vein, which is from the portal venous system, and the veins of the anterior abdominal wall, which are from the systemic venous system. So please remember the sites, please remember the component veins which forms the anastomosis, and I think you will be never wrong in this particular question based on this particular concept, right? So for this particular MCQ, the answer is the left gastric vein and the hemiazygous vein. This question we have already discussed again in FMG anatomy PYQ session. So a patient has numbness over the radial 3.5 fingers. I think this is quite obvious the moment you get these kind of word. So numbness, radial 3.5, volar side, of course volar side, and of course there is compression of median nerve, and that entity is known as carpal tunnel syndrome. And for carpal tunnel syndrome we do one test that is known as Durkan's test. So I think it's quite easy because the classical presentation is suggestive of carpal tunnel syndrome, which is compression of the median nerve. And we teach students about the Phelan test, in which we do palmar flexion for 1 minute so as to increase pressure over the median nerve and resulting in the aggravation of the symptoms. But here the test name given is different, that is Durkan test. And what actually we do in Durkan test, we give a direct pressure over the median nerve, right? So we will press the median nerve, and it may be for around say 30 seconds or so. And again, if there is pressure over the median nerve, that will result in aggravation of the symptoms of median nerve compression. So it is again first, second, third, and this is half, right? So this is half here. So this is the concept of the 3.5 fingers lateral aspect, right? Because this is thumb. So this 3.5 volar, this is of course volar surface of palm. So 3.5 volar surface is all territory of median nerve, and whenever there is compression of median nerve, usually in the carpal tunnel, okay, in the carpal tunnel, so median nerve compression, right, and that results in aggravation of numbness, tingling, burning sensation or pricking sensation. So that we call paresthesia. So that is paresthesia, right? So classical carpal tunnel syndrome, and I think there should be no confusion in this particular question whatsoever. Okay, chalo, next question. Identify the histological slide. Yes, identify the histological slide. Anyone? What we can see here in the given slide. Yes, what we can see here. Anyone? Okay, let me explain the picture first, and I think then it will be very easy for you to answer, right? So if I draw this, okay, this is one thing, then there is a space, okay, there is this space, and finally on the inside we have capillaries, okay, so we have capillaries inside, right? Now would you like to change your answer, Varun? Capillaries inside, limiting membrane outside, and a potential space in between the two. These are all capillaries. This is space, and this is one membrane. Yes, absolutely right, Varun. Now you are right. This is glomerulus of kidney. So these capillaries are actually the glomerular capillaries, okay. This space is actually the Bowman's space, and this membrane is actually the Bowman's membrane, right? And yes, it's the afferent and efferent are not clearly visible in this, but this is a classical picture of a classical histological slide of glomerulus, which is also known as renal corpuscle, right? So this is glomerulus. So these are all capillaries with mesangium in between. Okay, so this is glomeruli. So here we can see on this is the Bowman's capsule, okay, right, and then we have the Bowman's space. This is all Bowman's space, okay, and then we can see the capillaries inside. So all capillaries and mesangium, and here in this picture we can see the afferent and the efferent arteriole, right? So afferent and efferent can be seen better in this picture, in this slide, right? So this is a classical glomerulus, okay. Chalo. Next question. Marked opening is present in which of the following structures? So if you see here, the arrow is here, right, and this is actually deep inguinal ring. So I've just given a labeled image for your convenience, and there is one more opening which is the superficial inguinal ring, right? And yes, needless to say, this all is the inguinal canal. Okay, so this all is the inguinal canal. So the deep inguinal ring is a defect in, yes, anyone? Deep inguinal ring is a defect in deep inguinal ring is, yes, KK, you are absolutely right. So deep inguinal ring is a defect in fascia transversalis. I am repeating again, fascia transversalis, and please don't mark as the muscle proper. So it is not the muscle proper, it is the fascia of the muscle, right? So this is deep inguinal ring here in the fascia transversalis, and the superficial inguinal ring is a defect in external oblique aponeurosis. So again, please note that it is not the muscle proper, it is the aponeurosis part, right? So this is deep inguinal ring and superficial inguinal ring, and here this dotted line actually represents one artery, and this is the inferior epigastric artery, right? And if you know the anatomy of the Hasselbalch's triangle, so this is the Hasselbalch's triangle. Clear? So this is the Hasselbalch's triangle. Clear? So this is in short for this question. So again, you can see this is the deep inguinal ring here. So this is the deep inguinal ring, defect in fascia transversalis, and superficial inguinal ring, which is a defect in external oblique aponeurosis. Okay, chalo. Then moving on to the next question related to the same concept. Yes, very good, Kakul. Now next question, again from the same concept but a clinical presentation. Now, weakness of which structure will result in hernia medial to the inferior epigastric artery and above pubic tubercle? Now I have already told you what is the location of inferior epigastric artery. So if we draw in this image, this is the inferior epigastric artery. Okay, so the question is saying that the hernia will be occurring something like this, and when the herniated bowel enters into the inguinal canal medial to the inferior epigastric artery, this is known as direct inguinal hernia. Clear? So the question is about direct inguinal hernia. Clear? Now it means the structure will be entering through the posterior wall of inguinal canal, right? So the herniated bowel loop will enter through the posterior wall of the inguinal canal, and I just want to check that how many of you can answer the structure which is forming the posterior wall of inguinal canal, right? So again I am repeating, posterior wall of inguinal canal. So this is slightly tough because you should have a 3D kind of impression in your brain. So anyway, the answer to this question is actually the conjoint tendon. Okay, so answer is conjoint tendon, and let me explain you how it is. Now what is conjoint tendon first? See, the word is joint, so there is joining of internal oblique plus transversus abdominis tendon. Okay, so suppose if this is internal oblique and this is transversus abdominis, Okay, so this is transverse abdominis, this is internal oblique. Then they form a common tendon, right? They form a common tendon, and this tendon is known as conjoint tendon, right? So this is conjoint tendon. Now conjoint tendon is on the posterior side of the inguinal canal. So what I mean to say that this forms the posterior wall of inguinal canal, right? So if you look in this image, this is the internal oblique muscle, okay, and then this is the transversus abdominis muscle, and together they form the conjoint tendon. So whatever I am drawing in red is the conjoint tendon, okay. Then this all area is the inguinal canal, okay. So this all area is the inguinal canal, and you can see the spermatic cord in case of males. Lower down the inguinal canal there is the inguinal ligament. So this is the inguinal ligament which forms the floor of the inguinal canal, right? So the bowel loop will come something like this from the posterior wall through the conjoint tendon, right? So that what is the answer to this particular question, that the case is about direct inguinal hernia, and we know that in direct inguinal hernia the content enters into the inguinal canal through the posterior wall. It is only in the indirect variety where the content enters through the deep inguinal ring, something like this. So this is the indirect variety, right? Indirect, it is going through the posterior wall, and for posterior wall please remember conjoint tendon, right? And here in this image you can see this is the conjoint tendon here, okay. So this is the conjoint tendon here, and it is lying behind the inguinal canal. So this is the inguinal canal, okay. And somewhere here is the inferior epigastric artery. So inferior epigastric artery, okay. So this is the concept of actually the direct inguinal hernia which is asked in this question, okay. So now let us move on to another question, and this is again related to the same topic. A elderly patient underwent repair for bilateral inguinal hernia, and there was placement of the mesh. Now he is having pain or sensory disturbances in the lateral part of the thigh. Now which nerve entrapment has occurred, or means this is neuropathy, you can say entrapment neuropathy. So the moment you find this particular word, lateral side of thigh, so the lateral side of thigh gets innervation from lateral cutaneous nerve of thigh. Clear? So that nerve is lateral cutaneous nerve of thigh, and this clinical syndrome is known as Meralgia paresthetica, right? So this is known as Meralgia paresthetica, and this is the classical picture, right? The patient will come to you and he will say that there is numbness, pain, tingling, burning sensations on the lateral aspect of the thigh. So the moment you get this kind of presentation, the answer has to be lateral cutaneous nerve of thigh. So very classical presentation for Meralgia paresthetica, especially this area. So this is all territory of the lateral cutaneous nerve of thigh, and it can be involved post-operatively. Sometimes it is entrapped or compressed behind the inguinal ligament. So compressed behind inguinal ligament. So this is of course one scenario, this is another scenario, and especially we see this kind of presentation in obese persons or who wear tight clothes like underwear or pajama, whatever. So that way there can be compression of this lateral cutaneous nerve of thigh behind the inguinal ligament, and patient will come to you with this classical, yes KK, you are absolutely right, this is Meralgia paresthetica, right? So a very common condition in clinical practice. Now identify the bone, identify the ear ossicle, very good KK, this is incus. And yes, sometimes there is, some people might think that it is malleus, but it is not malleus, it is incus. So just to have this basic description of the two bones, the incus and malleus. Of course stapes is quite easy to identify. So what we see in incus, there is a head, there is a short process, and there is a long process, right? So a head, short process, and a long process. So here you can see this is head, this is short process, and this is long process. Okay, so just and this is of course the articular area. So this is the incus. Now what we see in malleus, almost like sometimes it looks like incus only. So there is a head, there is the manubrium, and then we can see processes like of course there is one neck, then there is one lateral process, then there is one anterior process. Okay, so this is the classical malleus. And of course incus, the stapes is quite easy to identify. We can see a small head followed by a small neck, then two limbs and the foot plate. Okay, so this is stapes. So the differentiation has to be done between incus and malleus. Of course malleus is quite larger in terms of size as compared to incus, right? So this is incus. Then now this is again a very important topic from which we have questions many times. So ventral mesogastrium, dorsal mesogastrium. So the arrow is on this structure here, and it was asked like what will develop from this structure. Yes KK, you are absolutely right, this is falciform ligament, right? So this is actually the ventral mesentery, or what we call the ventral mesogastrium, and this area on the posterior aspect is the dorsal mesentery or the mesogastrium, and this area in between this all is the primitive gut, right? So this is early stage of development, and later on there is formation of stomach, spleen also. Like, so if we go in terms of weeks, so initially what we see around the 4th week, so what we will see around the 4th week, we will see the ventral mesentery. This is ventral mesentery, and then we will see the dorsal mesentery here. So this is the dorsal mesentery, this is the ventral mesentery, okay, and this is the primitive gut, right? And then around 5th week we will see this is liver, this is stomach, right? So this is stomach and this is spleen, okay. And even we go further around 10th week, we will see that there is, now here you can see one thing, the ventral mesentery, right? Like the ventral mesentery is anterior and the dorsal mesogastrium or mesentery is posterior. So this is in this plane, right? So somewhat like this plane. But what happens later on, there is rotation of gut, right? So there is rotation of stomach, and what will happen, the ventral will come onto the right side and the dorsal will move to the left side. Okay, so there is rotation. And then further on there will be, this is of course the falciparum ligament, liver. Then between the stomach and the liver there is gastrohepatic ligament or the lesser sac. Then between the stomach and the spleen there is gastrosplenic ligament, and between the spleen and the kidney there will be lino-renal ligaments, right? So this is very important. So in short, if we just this will be you say this will be liver, okay, this will be liver, and in front of liver there will be falciform ligament. So this is falciform ligament. Then here we have the stomach, something like this. So this is the stomach, and then posterior to stomach we have the spleen. Okay, so this is the spleen, and even posterior we have the left kidney. So this is the left kidney. Okay, so the structure which is the ligament which is extending between the spleen and the kidney is lino-renal ligament or spleno-renal ligament. Okay, the ligament which is extending between the stomach and the spleen would be known as the gastrosplenic ligament, and the space between the liver and the stomach, this is the lesser sac, okay, or gastrohepatic ligament. Sometimes you will find this as well. So this is between liver and stomach, okay, this is between the stomach and the spleen, and this is between the spleen and the left kidney, right? So these are the common, and this one is of course falciparum ligament. So you should know these four structures: 1, 2, 3 and 4. So most of the time the question is based on these points only, and the pointer will be somewhere at either of these places, and you have to identify the structures in terms of the development of ventral mesogastrium and dorsal mesogastrium. So this is again a very important topic, and most of the times we have a question from this segment. Okay, chalo. Now identify the histological slide. What you can see here, yes, anyone, what is the histological slide? This is histology of pancreas, okay, and when I say histology of pancreas, I think most of you can answer what is this actually. Here we have alpha cells, beta cells. So what is that? Alpha cells, beta cells. KK, would you like to revise your answer? Anyone? Alpha cells, beta cells. Beta cells secrete insulin. Now I think you should be able to answer it. What is this? Yes, anyone? Very good, Ravi. This is islets of Langerhans. And if you see the darker cells, these are the alpha cells which secretes glucagon. Okay, so these are the alpha cells and they secrete glucagon. And if you look at the lighter cells, these lighter cells are the beta cells, and these beta cells secretes insulin. Okay, so lighter cells are all beta cells which secretes insulin. Okay, so these are beta cells and the darker cells are alpha cells. Clear? So this is histology of pancreas, and this area is specifically the islets of Langerhans, which is actually the endocrine part of pancreas, right? So this is endocrine pancreas, right? So this is all endocrine part. Chalo. Now what you can see here, this we have already discussed while we are taking the PYQs of FMG anatomy, and there also we have, although we discussed another type of cartilage, but here this one is different. Now let me see how many of you can answer this. And in fact, I tell you, this is one of the easiest type of cartilage to identify because of the classical okay, let me simplify. You can see the cells, they are arranged in rows, and then you can see the collagen fibers all around. So this is fibrocartilage. Clear? So the easiest of all to recognize in terms of cartilage, this is fibrocartilage, right? So easiest. Hyaline is slightly different. In hyaline, you will see a clear background. Right? So you will see chondrocytes against a clear background. That's very important. Now here, the background is not clear. If you see, you can see fiber something like this. So this is not a clear background. It is something like this, okay? So you can see the chondrocytes. These are all chondrocytes arranged in rows, and in between them there are the collagen fibers, something like this, okay? So this is a typical fibrocartilage, right? So here you can see the chondrocytes, and there are collagen fibers. So these are all collagen fibers like this, right? So fibrocartilage is the easiest to identify, and in hyaline the background is clear, whereas in elastic you might see elastic fibers in the background, right? So there are elastic fibers in the background in cases of, so these are all elastic fibers in between the chondrocytes, right? So this is the elastic cartilage. Anyway, this one is fibrocartilage, and I think most of you must be knowing what are the locations of fibrocartilage. Especially you can recall about intervertebral disc, okay? So this is fibrocartilage. So that's enough for this session, and we will have few more questions tomorrow 10:30 p.m. and I'll try to take maximum anatomy PYQs from the NEET-PG exam of previous years, right? So with that we end today's session, and I'm extremely thankful to all of you for spending your valuable time with me, and see you tomorrow 10:30 p.m. and we will take some more interesting MCQs of anatomy NEET-PG exam. Good night. Take care.